Hey everyone, welcome back to Static Pharmacology here on EMTV. I'll be giving you a patient care scenario, and your goal is to develop a treatment plan that emphasizes pharmacological management. For an extra challenge, I'll be putting a 1-minute timer on the bottom of the screen. When the time is up, we'll do a scenario walkthrough, and I'll give you my treatment. Enjoy the card, and good luck.
3, 2, 1.
For this card, I thought I'd give you a basic VFib arrest. Let's go ahead and take a look at the scenario in a little bit greater detail. You are dispatched with an engine company to a private residence for a 66-year-old male who suddenly became unresponsive and collapsed. Upon arrival, you witness family members performing chest compressions. You attach your monitor and note that the rhythm is coarse ventricular fibrillation. For those unfamiliar with what coarse ventricular fibrillation looks like, here's an example. We'll talk more about this condition in a little bit. Your paramedic partner confirms that the patient is pulseless, while the BLS providers on the engine begin performing CPR and delivering ventilations. The family reports that the patient has an extensive cardiac history that includes coronary stent placement 6 months ago. Pads are placed on the chest, the defibrillator is charged, a shock is delivered, and CPR is resumed. Most vital signs are unobtainable, but attached capnography displays a CPR wave with a value of 12 millimeters of mercury. There is no reported trauma, ventilations are being delivered without difficulty, and a rapid physical examination reveals no other pertinent findings. This scenario involves the care of a patient in ventricular fibrillation. Ventricular fibrillation is a disorganized, chaotic depolarization of multiple sites within the ventricles that can occur for a variety of different reasons. The chaotic nature of the non-uniform depolarization of ventricular myocytes results in a quivering-like motion of the heart. Because of this, there is no cardiac output associated with ventricular fibrillation, and as such, no palpable pulse. Ventricular fibrillation can be caused by a variety of different reasons, but because of this patient's history of advanced coronary artery disease and a coronary stent placement 6 months ago, we can assume that this was very likely the result of a ST segment elevation MI, or STEMI, that affected his left ventricle, so it is very likely that this patient is suffering from an occlusion in the left anterior descending branch of the coronary artery, or perhaps the circumflex. Although pharmacological interventions are important for a patient in ventricular fibrillation, or VF, the only treatments that have been shown to effectively reverse ventricular fibrillation, if administered quickly enough, are early CPR and early defibrillation. Defibrillation is when energy is passed through the heart's muscle in order to disrupt the chaotic nature of ventricular fibrillation and allow the heart to restart itself in a more normal, organized rhythm. Unlike what is shown commonly on television or in movies, asystole or flatline is not defibrillated. Defibrillation is only successful if it is allowed to disrupt disorganized electrical activity, whereas asystole is the lack of electrical activity. To put this another way, defibrillation can be thought of as hitting Control-Alt-Delete on your computer when it begins to malfunction, so that it can hopefully restart itself in a more organized fashion. Control-Alt-Delete is only effective if your computer is on. It would be pointless to hit Control-Alt-Delete to restart a computer that isn't even plugged in. If left long enough, coarse ventricular fibrillation eventually progresses to finer and finer ventricular fibrillation, and then eventually into an asystolic rhythm. Now that we've talked a little bit about VFib and the importance of defibrillation, let's go ahead and move on to the treatment. Just like with all my other cards, I'll begin treatment by regurgitating the mantra, Scene Safe, BSI, IV O2 monitor. I'll then continue cycles of CPR and defibrillation. The first medication I'll consider is epinephrine, 1 milligram of the 1 to 10,000 concentration, and this will be given every 3 to 5 minutes, IV push. Because this is a ventricular dysrhythmia, I'll then consider administering amiodarone. Amiodarone is actually given in 2 doses for persistent VFib or pulseless VTAC. The first IV push dose is given 300 milligrams, and this is after the first dose of epinephrine. Because epinephrine is given every 3 to 5 minutes, and cycles of CPR are traditionally 2 minutes long, amiodarone is given the following cycle of CPR after an epinephrine dose. The second dose of amiodarone is 150 milligrams. This of course will follow a dose of epinephrine. After you've maxed out your amiodarone dose, if you still have persistent VFib or pulseless VTAC, you'll move on to a second-line ventricular antidysrhythmic. Lidocaine is a good choice for this. Lidocaine is given at a weight-based dose of 1 to 1.5 milligrams per kilogram, rapid IV push. Subsequent doses are given at 0.5 to 0.75 milligrams per kilogram. These are given every 5 to 10 minutes, up to a maximum total dose of 3 milligrams per kilogram. If your patient is still in persistent or recurrent ventricular fibrillation or pulseless ventricular tachycardia, you could then also consider percanamide. Percanamide is given as an infusion at 20 to 50 milligrams per minute to a maximum dose of 17 milligrams per kilogram. Once you've achieved the dose of 17 milligrams per kilogram, the infusion is stopped. At this point, remember you are giving epinephrine every 3 to 5 minutes. The cardiac arrest event has been ongoing for a significant amount of time. An additional ventricular antidysrhythmic that you could consider is magnesium sulfate. The asterisk is present because magnesium sulfate is generally only included in an arrest event if you suspect the cause of the arrest to be hypomagnesemia, or if the patient is in torsades, a specific type of polymorphic ventricular tachycardia. Beyond this, you can consider the H's and T's, or the reversible causes of cardiac arrest, as a basis for additional pharmacological management. And finally, rapid transport. And that's it. If you enjoyed this card, please make sure to head over to my channel for more. And while you're there, make sure you check out my other playlists, Static Cardiology, as well as Paramedic Pathophys. Thank you again for liking and supporting my channel, and stay tuned for new content coming soon. Until I see you next, stay safe, keep washing your hands, and have a good rest of your night.